A 70-year-old lady presents to the clinic with an asymptomatic small femoral hernia that was detected incidentally when addressing other unrelated complaints. What would you do in this situation?
I would offer the lady an expedited mesh repair of her femoral hernia, ideally within 3 months, due to the higher risk of incarceration and strangulation, and thus excess mortality with this type of hernia.
What approach or techniques would you use, and how can you support your decision?
Whilst both options of elective open and laparoscopic repair are acceptable, in the absence of contraindications, I would utilize a laparoscopic transabdominal preperitoneal approach. A large Danish study including almost 4,000 patients demonstrated that in open cases, there is a significantly greater risk of reoperation and recurrence, including the recurrence of an inguinal hernia in the same groin. Laparoscopy also has several key advantages, including providing easy access to the hernia site, the fact that it always utilizes a mesh, and better discrimination between inguinal and femoral hernias. In one study out of 33 patients who had femoral hernia repairs, 60% had previous open inguinal hernia repair, suggesting that at least a proportion may have been originally misdiagnosed. Primary open suture repair has consistently reported higher rates of recurrence compared to placement of a mesh in both open and laparoscopic contexts. Whilst erosion of the mesh into surrounding structures including bowel, bladder and femoral vein has been reported, these are quite rare occurrences. The latter may be associated with femoral vein occlusion and development of a DVT.
A patient presented acutely with an incarcerated groin hernia. During groin exploration for an incarcerated hernia, the hernia sac slipped inside the abdomen before you managed to explore it. What would you do, and what is your rationale for doing so?
There is a possibility that the reduced sac contained infarcted bowel, and therefore, I will attempt to visualize the bowel through the sac by utilizing a laparoscope. This is often referred to as a hernioscopy. If the bowel was visually proven to be not ischemic, then this would provide the necessary assurance and avoid the need for a reoperation due to perforation or ischemic stricture. In a randomized trial that assessed patients whose hernia reduced spontaneously, 2 patients underwent an emergency laparotomy, and 2 more died in the group, who did not have a hernioscopy, out of a total of 20 patients. There were no recorded complications in 21 patients who had a hernioscopy.
If the surgical field is contaminated, how could your technique differ?
In the acute setting, I would utilize an open preperitoneal high approach instead of a laparoscopic technique. I would generally perform suture repair of the femoral ring, whilst allowing room for the femoral vein that is positioned just lateral to the femoral ring. I would avoid placement of a synthetic mesh if there was evidence of contamination, such as strangulated bowel perforating into the sac, or an abscess. However, in the context of a strangulated bowel requiring bowel resection, utilization of mesh repair is still comparably safe and superior in terms of recurrence rates, as long as a clean operative field is observed. This is confirmed in a 2014 meta-analysis of 9 studies, including 2 RCTs.